All right, guys, welcome back. I got grouped a couple things together here, and let's talk about them real quick. And my pen is not helping me here today. All right, so what we're going to talk about first, of course, is cardiac tamponade. So I got my nice little heart here. But remember that there's two layers around the heart. There's the parietal. Again, the parents are on top. The parents cover everything, right? And the visceral. The visceral goes against the organ itself. And so what happens is we get something that causes fluid to come into this area. Yeah, that's nice. That's wonderful. That's great. Only problem is what happens is it starts pushing on the amount of space that the heart actually is able to fill up. So it's going to decrease the fill of the heart. Now, obviously, the farther this goes, the worse this is going to get, until eventually it's not. And by the way, your heart, it tries to compensate for your cardiac output, usually by increasing the heart rate. So you're going to see tachycardia with this usually. But the problem is again, remember that cardiac output, again, is heart rate times the stroke volume. Well, that's great that this is going up, but what's happening here is actually the stroke volume is actually going down, okay? And eventually it gets to the point where the stroke value becomes this guy right here. All right, well, it doesn't matter what the heart rate is at that point. Our stroke volume is 0, so our cardiac output would be 0, and then, of course, you're dead. Now, again, so it's usually caused by a trauma. If you've got an MI, you can actually have the tissue bust and it leaks fluid into that area as well. So that's kind of why we include tamponade in with this particular setting. Again, usually benign presentations might be caused by cancer or pericarditis, renal disease, or hypothyroidism. But all of these things can have a contributing factor to cardiac tamponade. Usually, if it's cancer related, again, it's usually a tumor that's pressing against the heart, which doesn't allow it to fill, and it loosely falls into that same category. Now, again, precipitating causes is our index of suspicion. That's what we want. And then the patient's going to relate a history of shortness of breath, and especially positional shortness of breath. That's what that lovely word means right there, is the orthopnea. All right. So what do I do with this? Again, you're going to have a rapid weak pulse, a decreasing systolic pressure with a narrowing pulse pressure. Remember, we said it fills, and the problem is that it decreases the fill. That's going to narrow the systolic and diastolic pressures, okay? Pulsus paradoxus is going to happen. Again, it's going to start reducing that. Again, and it's because you got more pressure in the thoracic cavity. You may hear faint or muffled heart sounds. It's going to sound like, instead of lub-dub, you're hearing lub-dub. And so it's very difficult. And then electrical alternance. So you're going to start seeing electrical irritability in that where it shouldn't be. Matter of fact, it might even go into VTAC because it's trying to compensate. And unfortunately, that's not obviously going to work. So what do? How do we manage cardiac tamponade? The definitive treatment is to drain off that fluid, okay? However, unfortunately, we don't have that choice usually in the pre-hospital setting. Get them to somebody that can, all right? So administer oxygen, IV access, I would probably limit my fluids on these folks. Again, you can try to give them more. Dopamine or dobutamine, again, it's going to help the squeeze. But remember, that's kind of a self-defeating prophecy of this. You can try morphine and again nitrous oxide, throw him out. We don't like him anymore. I would probably not use nitrous on this guy. Lasix, we can try to drain it off. Again, that's kind of it's a longer term situation. Same thing if they have a pericardial effusion. These work actually pretty decent for a pericardial effusion, but not per se a cardiac tamponade. The definitive treatment, ladies and gentlemen, is to get them to somebody that can do a pericardial centesis. Drain it out, aspirate, again, and this should only be performed by local protocol. and it should only be personnel that are trained to do so. And for that moment, now let me just say, you're not trained to do it. You're trained to recognize it and get them to somebody that can stick it. Don't forget, guys, your critical care medics have the ability to do this. So get the closest critical care medic to you to do this procedure. Guys, really, it's a 3-inch spinal needle that you use, 3 to 4-inch spinal needle that you're using. It's not a difficult procedure, but it's got to be done by somebody who is trained to do it. All right? Hypertensive emergencies. Usually it occurs only in a history of patients with hypertension. I'm going to stress this, that you don't, there's such a thing as permissive hypertension. We're talking about a true hypertensive emergency where you've got a lot of clamp down of the vessels due to a response within the body, okay? And the primary cause, by the way, is you didn't take your prescribed medicines like you were supposed to, okay? Toxemia of pregnancy is the other one where this can occur. And again, we use mag sulfate at that point to help lower the blood pressure on these folks, okay? Especially if they start to seize, all right? Actually, true hypertensive emergencies, guys, usually I found between the ages of 30 and 50, okay? So it's kind of weird. And actually, black males are probably a little bit more susceptible. Not that the females can't have it, but African-American race is actually one of the bigger ones for that one, okay? And it usually probably has something to do with either their kidney or kidney function, or they've got chronic hypertension. All right? So again, they're going to have alterations in mental status. They're going to be complaining of blurred vision, shortness of breath. They may have a nosebleed. The room is spinning. They're ringing in the ears. Headache caused by nausea and vomiting. Okay? Now, if you look at these symptoms kind of match up with a stroke. So how do I know which one, how do I know? Usually strokes take your blood pressure up to a certain point. The other thing is if you got a brain bleed, all of these are signs and symptoms of a brain bleed. So how do we know? Back to here, initial assessment and get your history, okay? Get your history on these folks, okay? It's amazing how that history is going to pay dividends right there, okay? So it's usually a known hypertension, and find out their compliance with their medicines, okay? The blood pressure 160 over 90. I'm going to be honest. I'm not even thinking about controlling this until probably 200 systolic or 110 diastolic. And again, it's not for a short period of time. A patient can usually withstand this. Now, if I'm coming, from 2 hours away, I might call a doc and say, and most of these, by the way, if you're going to treat hypertensive emergencies, you usually do this via physician consultation, okay? Again, if you got lines of left-sided heart failure, actually, this is one of the few times where I'd say getting the blood pressure down is good because you're reducing the afterload, which reduces workload on the heart. You get a strong bounding pulse with this. The skin will be flushed, probably a little bit on the warm side, okay? You're probably going to have edema going along with this. Again, there's other ways to get this down, though, besides the true shotgun blast of this. And I would say probably this guy right here is probably my first line, which is to give him some nitroglycerin and hopefully cause those vessels to dilate. Again, it's somewhere else for the pressure to go, okay? So, again, hypertensive emergencies, again, if it's a true hypertensive crisis, most of the time that's due to an alpha response, okay? It tightens down the blood vessels, all right? But you can have the hypertensive emergencies with the heart pumping too hard, okay? That is a possibility, all right? Your body then dumps more adrenaline in because it thinks it's not getting enough, which causes the problem to get even worse, okay? You can also see this happening on your heart failure patients. It's an initial response, okay? It's an initial response to make things better, all right? So let's dilate them out. Can we give them some Lasix? Let's get rid of some fluid, especially if they've got edema, okay? This is probably a really good idea if they've got edema or more importantly, pulmonary edema, right? They got pulmonary edema, definitely, okay? Again, morphine sulfate dilates the venous system. We kind of like that. Nitroprusside, again, relaxes those. It will help create pressure. So this will lower the pressure, which will make things, it reduces the afterload, reduces preload. Labetalol is the other one, and you're going to see this when we get into start talking about strokes, okay? Now, the cool thing about labetalol is that it reduces as far as the heart rate, it has actually, I would say, like very, 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 very little going down. But the good thing is the squeeze, it definitely does the squeeze, okay? It definitely reduces squeeze to the heart on this guy. So that's why we really do like the labetalol from that. All right, cardiogenic shock. And I'm going to wait on the cardiogenic shock till no, I'm going to do that one on this one. So where we had the hypertensive emergency here, okay, that's the one extreme. The other extreme with cardiac event is the pump has failed, okay? This gives us a cardiogenic shock, all right? So what are some causes of cardiogenic shock? Again, I've got a heart muscle that has been damaged, either by physical trauma or by no oxygen to it, okay? I've got a tension pneumothorax or a cardiac tamponade that's pressing it, which is impairing the ventricular filling. I've got damage to the muscle that's causing it not to pump blood the way it's supposed to, okay? The very unfortunate part about this, gang, is that the mortality rates, especially if we have a pump failure in the pre-hospital setting, pump failure is usually, it's like, uh-oh, this patient's getting ready to go, okay? So it's not able to meet their metabolic needs, and the way to correct that is to speed the heart up and make it squeeze harder. Oops, I guess that's going to be an issue, okay, because the pump has failed. Now, so with that being said, a high mortality rate is very common with this to happen, okay? If they're in cardiogenic shock on you, probably not a good thing. Now, again, our initial assessment of the patient, let's assess them correctly. Let's look at chest pain, shortness of breath, that they're unconscious, they have an altered mental state. It can be an acute or a progressive, so it can come from a long time or just hey, 5 minutes ago he was awake and now all of a sudden, he's had a massive heart attack, and literally where he had 70 cc's of blood squeezing on every stroke, it's now 5 cc's, okay? And again, this is something that can happen as a complication to a myocardial infarction, okay? Presence of shock or the absence of trauma. That's kind of a dead giveaway to a cardiogenic shock case. There's no sepsis involved. There's no reason why they'd be losing fluid, okay? You have to suspect cardiogenic shock at that point. They're going to be restless, confused if they're even awake. And again, remember that the brain likes its oxygen, it likes its fuel. So again, the brain is probably going to get it, but everywhere else probably not getting it at this point, not getting any type of nutrients. All right. You're going to have labored breathing, cough. The patient might be in a tripoding position. They might be trying to use accessory muscles. Remember that requires energy. Pumps failing, no energy is getting to the cells. They're in a lactic acid state. They're not producing. They're not in the citric acid cycle where they're producing a bunch of energy. They're going to a dying situation. Again, tachycardia. They may actually be in an atrial dysrhythmia. Okay, so your atria might be trying to speed up in this case with the cardiogenic shock. All right. So again, they're probably going to be hypotensive. They're going to be cool and clammy. And again, our management priorities with these guys. Again, maintain the airway, identify and treat the underlying problem. Good news is if it's something impairing the ventricular filling, tamponade, pneumothorax, you fix that problem, hey, guess what? They get better, all right? If it is a true pump problem, if they're having a heart attack, get them to a cath lab, okay? But in the meantime, we've got 25, 30 minutes in order to get them to the hospital, All right. Aggressive fluid therapy. I'm going to tell you why that's a double-edged sword right there, okay? And I say that considerate. The problem is usually at this point, they're not able to, the preload, afterload contractility, the problem is if that's damaged, you got to increase this. Most of the time, these patients are fine with preload and afterload. Matter of fact, they simply can't overcome the load that's there now, okay? Vasopressors is probably going to be your treatment of choice. And, of course, our vasopressors that we have is, of course, dopamine, and that's probably our first line. And the one that's gaining more popularity is to hit them with some epi, okay? And these are both drips, by the way. So drip this one, all right? Go with the drips here, all right? Remember, 2 to 10, that's our speed. 10 to 20 helps the squeeze. So be thinking that 10 to 20 range when you're going with a vasopressor. For dopamine, for epi, you started at 2 milligrams a minute and then slowly increase it, okay? Again, once you get to 10 milligrams a minute or 10 micrograms a minute, you want to stop. So, by the way, so this is micrograms per kilogram, and this guy right here is just micrograms per minute. Okay? So micrograms a kilogram per minute for the dopamine, and then for the epi, it's going to be mics per minute. Other medicines that you can try, and I stress try here. Can we get a fluid off of it? Probably not. But again, guys, this is going to be your weapon of choice once they get into cardiogenic shock. All right? That's going to be your weapon of choice, and it's probably going to be this guy right here. And if you don't have that guy right there, it's definitely this one. Okay? The one that we really want to have, by the way, if they're in cardiogenic shock, is the old ugly stepsister, right? Dobutamine is actually, if you've got that flavor ice cream, that's the one that you want. All right? So again, cardiogenic shock. One of three things causes shock: volume loss, vasodilation, or pump failure. Okay? Again, abnormal heart rate, again, we can fix that pretty easy. All right? But your pump failure is what we're talking about here. Okay? So nitroglycerin, it might help. Lasix might help. But again, morphine sulfate, okay. It helps take some of the pressure off of there. So again, if you've got a pump rate, one of the other things that causes cardiogenic shock is if you've got a low heart rate, you got to speed it up. If you got a high heart rate, you got to make sure to get it back. So with that cardiogenic shock being present, make sure that that heart rate is between this right here. It really does need to be that. So again, above 150, it affects the ventricular filling. Below 50, there's just not enough cardiac output to actually go out into the system. All right. With that being said, we're going to hold off on this one because, boy, this one gets kind of thick. So we'll talk to you guys on the next one. See you then.